Hello, I would like to talk about some tips for microvascular complications of diabetes. My name is Dr. Mintazor. I'm presenting for my postgraduate study. To start with an outline, there will be introduction about diabetes and its complications, especially microvascular complications. How common are they? Signs and symptoms of microvascular complications, its management overview, and recommendations. As you all know, diabetes is one of the most common non-communicable diseases worldwide, and it is increasing rapidly. And so also are the complications of this disease, leading to poor quality of life and premature death. The complications of diabetes affect small and large blood vessels. And complications of diabetes can be seen as in this picture. Microvascular complications involve diabetic retinopathy, diabetic nephropathy, and also diabetic neuropathy. Macrovascular complications of diabetes involves brain, such as stroke, and heart, such as diabetic cardiopathy, arrhythmia, and other heart attacks. And also extremities, such as feet, involving peripheral arterial diseases. So to start with the definition of diabetic retinopathy, according to NHS UK, it is the complications of diabetes caused by high blood sugar levels damaging the back of the eye, that is retina. It can lead to blindness if left untreated. And diabetic nephropathy is defined as persistent proteinuria. It can progress to overt nephropathy. It is characterized by progressive decline in renal function resulting in end-stage renal diseases. Neuropathy is a complex condition associated with nerve damage. It can be classified according to the nerves affected. It includes focal, diffuse, sensory, motor, and autonomic neuropathies. And these complications are more common than we think. For example, retinopathy in type 1 diabetes is about 13% at 5 years after diagnosis of diabetes, but it rapidly rises to 90% after 10 to 15 years of diagnosis. And 25% of them will lead to proliferative retinopathy after 15 years. Regarding type 2 diabetes, 24%, that is about 1/4 of all the patients, to 40% will develop retinopathy at 5 years. After 15 to 19 years, that number can increase to 53 to 84%. Diabetic nephropathy is also common, about 30% in type 1 diabetes and 5 to 10% in type 2 diabetes. And 80% of type 1 diabetes and 20% of type 2 diabetes will lead to end-stage renal diseases eventually. And regarding neuropathy, although it is seen around 7% at 1 year after diagnosis, this can also lead to 50% at 25 years after diagnosis for both type 1 and type 2 diabetes. Now, I would like to talk a little bit about signs and symptoms of diabetes retinopathy. As you can see in this picture, in compare with normal eye with retinopathy have these pathologies in the blood vessels, or it will cause blurring of vision and loss of vision if untreated. There are two types: non-proliferative retinopathy, consisting of microaneurysms and retinal hemorrhages and exudates, which can lead to proliferative retinopathy with new vessel formations and vitreous hemorrhages. For diabetes nephropathy, there will be protein in urine. It starts with microalbuminuria at the microscopic level. And it can also be presented with hypertension, which sometimes detect increased creatinine level in patients. And patients can develop edema or symptoms of renal failure in advanced diseases. Diabetes neuropathy typically comes in stocking and glove distribution. This symmetric distal polyneuropathy is typical of diabetic neuropathies. Some patients will have loss of anger jerk and vibration senses. They can also complain of hyperalgesia and gut pain. Management is by early detection and early treatment to screen complications of diabetes. It should be done at least 6 monthly. For uncontrolled diabetes patients, that should be even more frequently. And the approach should be holistic to manage lifestyle and also with pharmacological treatment. For lifestyle management, medical nutrition therapy is the most important one. It also includes tight control of your blood glucose, your blood pressure, and lipid levels. To talk a little bit about medical nutrition therapy, the most important thing is to lower daily total carbohydrate intake and avoid sweet foods and sugaring products. Usually, lower glycemic index foods will result in lower post-meal glucose levels. The amount and source of carbohydrate will cause various glucose level. And restriction of glucose and sodium is important. And medical nutrition therapy should be combined with exercise. So the recommendation is to do exercise at least 30 minutes per day and 150 minutes per week. The more the merrier. These are the glycemic and blood pressure control targets for diabetes patients, according to AACE, American Association of Clinical Endocrinologists, published for 2015 guidelines. Actually, the glycemic targets and blood pressure targets for diabetes patients varies depend on the duration and severity of diabetes, and also with comorbidities, other diseases, if you may have, and also according to the lifestyles and age and so on. But generally, the fasting blood sugar should be maintained below 110 milligram per deciliter to prevent and control complications of diabetes. Random blood sugar should be below 140 milligram per deciliter. Hemoglobin A1C level should be below 6.5%, and blood pressure should be 130 by 80 millimeter mercury. Again, this is roughly the general idea, and your healthcare professionals will give you specific targets that is suitable for you. So, in conclusion, lifestyle management and pharmacological management, together with other lifestyle measures such as stop smoking if you smoke, intensive blood pressure control, medical nutrition therapy, will prevent macrovascular complications by 37%, according to the landmark diabetes studies, namely UKPDS. These are the references I have cited in my video clip. Thank you.